What's going on, guys? Tate Talks Medicine here with our Step 2 review series, and today we'll be talking about neurology, part 1 of 2 in this series. As a quick preface to this video, I wanted to clarify that this content was originally found on the Strudel Medicine channel prior to being moved over here, so if I mention Strudel in any way, that's why. The Tate Talks Medicine channel will now be the place to be for board and shelf review, along with other content focused on medical education at the student and resident level. As always, like, comment, subscribe, and let me know what kind of content you guys want to see next. And now, let's get right into it. We have case number one. A 35-year-old male with a history of IV drug use and chronic hep C presents to the ED with bilateral lower extremity weakness, back pain, and fevers. He reports that he has had fevers for the last 3 weeks and has been more fatigued on exertion. Vitals are significant for tachycardia and fever. On exam, you notice systolic murmur along with bilateral lower extremity weakness and point tenderness in the midline around the level of T7. Labs show a leukocytosis with a largely unremarkable chemistry and a marked elevation of ESR and CRP. What is the best diagnostic test to assess this patient's neurologic deficits? Okay, so specifically the history here, and then combine that with the symptoms. So history of IV drug use. This is epidermal hematoma or abscess. So an epidural abscess in this case with the fevers, the elevated ESR CRP definitely makes more sense. But really, this syndrome is defined by like the cord compression with the compatible history. So this patient is at high risk for endocarditis, bacteremia. You can get seeding and then an epidural abscess from that, as opposed to like somebody with a recent lumbar puncture, trauma can get a hematoma. Same symptoms, just might not have the infectious like fever and leukocytosis to go along with it. Your best diagnostic test when you're looking at the cord is going to be the MRI of the spine. If this is cord compression is being suspected because they have the lower extremity weakness and such. This is going to be an emergent MRI of the spine, so keep that in mind. And for this patient, because they have bacteremia, you're going to be treating this broadly. But first, you would want to draw those blood cultures. That's big in endocarditis. You want to draw the blood cultures first, and then empirically treat with a combination of vancomycin plus ceftriaxone or cefepime, depending on what you're kind of suspicion for. And remember, also, these can be drained if they're super large, like greater than 2.5 centimeters or about an inch. You would reach out to IR to have those drained. Otherwise, antibiotics alone, it's going to be a long course, but they would suffice. Case number two, we have a 78-year-old male with a past medical history of dementia presenting to the ED after a fall at his nursing facility. Per the staff, he has fallen multiple times over the last 6 months at home prior to becoming a resident there. They also report that he's had more confusion and incontinence. He has also been complaining of headache and blurry vision over recent weeks. A non-con CT of the head is ordered. What would you expect to find, and what is the underlying pathophysiology of the patient's condition? So we have a past medical history of dementia. Now we have a lot of falling, incontinence, and just it seems like confusion, without any history, with like the history of like maybe some head trauma. So it's important to be suspicious of this. This is a chronic subdural hematoma. So keep in mind the subacute to chronic onset in this case. The CT would show this crescent-shaped hypodensity that can cross the suture lines. As you can see over to that side, that's more in the frontal area rather than on one of the sides. But you usually get a picture of it over on the sides, more covering the parietal lobe and a little bit of the frontal lobe. The pathophysiology here is very high yield as well. So this is because of tearing of the bridging veins. So you're going to have an increased risk of these subdurals in patients with cerebral atrophy. So that can be due to like alcohol use on a chronic basis, just being elderly, dementia with cerebral atrophy can also be a risk factor for this. Your treatment is going to be really dependent on what's happening. So in this case, we're pretty darn symptomatic, it seems like. So neurosurgical evaluation would probably be warranted for this patient, but especially if they give you, you have pupillary deficits, you have midline shift on your CT, then definitely you'd want to evacuate that with the help of neurosurgery to help relieve those symptoms. So keep that in mind, specifically with the risk factor of cerebral atrophy and then the crescent-shaped lesion. You got to be able to recognize that on exams. So case three now, a 68-year-old female with a fast medical history significant for uncontrolled hypertension and subarachnoid hemorrhage 5 years ago presents to the clinic at behest of her children for increasing falls and forgetfulness. They report this has progressively worsened over the past 2 months and that she was previously normal from a neurologic perspective. They also note that she's been having increased episodes of urinary incontinence during this time, but she did have some history of stress incontinence prior to this. Vitals and labs are without major abnormality. An MRI is done showing ventriculomegaly with no evidence of masses or obstructive hydrocephalus. What is the best next step in management of this patient? So keep in mind the history. Once again, we have a history of subarachnoid hemorrhage. Now we have falls, forgetfulness, and worsening incontinence. So that triad right there, this is normal pressure hydrocephalus or MPH. So remember, this is caused by decreased CSF due to damage of the subarachnoid villi or the subarachnoid granulations. This is basically due to past intracranial hemorrhages, past subarachnoid hemorrhages, maybe meningitis in the past. And because of the scarring of those subarachnoid villi, you can't reabsorb the CSF the same way, so it'll build up and give you hydrocephalus. The classic triad there: wet, wacky, wobbly, incontinence, dementia, and ataxia, causing poor balance. The best next step is going to be a lumbar puncture showing a normal or mildly elevated opening pressure. Remember that the gait will improve after drainage in this syndrome specifically. So if it's some other pathology, then your gait will not be affected by the LP. But getting that excess CSF out of the system will improve the gait pretty quickly in normal pressure hydrocephalus. So keep that in mind. The treatment for this, which is also pretty high yield, is VP shunt placement. So here, remember that's a ventriculoperitoneal shunt. You're going to take CSF from the brain and you're going to shunt it down into the peritoneal cavity down in the abdomen. So case number 4, a 59-year-old male with past medical history significant for hypertension, hyperlipidemia, and CAD presents to the ED with sudden onset right-sided paralysis and aphasia. The patient's wife reports that the symptoms began about an hour ago. Vitals are significant for hypertension of 155 over 93 and an irregular tachycardia. A non-con CT is ordered revealing no evidence of hemorrhage. What is the next best step in management of this patient? So this is kind of a bread and butter neurology case here. Sudden onset. It's been an hour. He has a little bit of hypertension, irregular tachycardia as a risk factor, and no hemorrhage on the CT. This is an ischemic stroke. Classically, the symptoms of this is pointing to the left MCA territory. But the first step when you see these symptoms is going to be a non-con CT of the head to rule out hemorrhage. That's your first decision point. So keep that in mind. That's very high yield. If the CT is negative, like in this patient, no hemorrhage, then the next best step is TPA, which is thrombolytics. Typically, this is okay within 4.5 hours of last known well, unless they have a contraindication to TPA. That's usually things like, recent GI bleeding, history of intracranial hemorrhage, I believe like an aneurysm, active aneurysm would be a risk factor. Those are pretty high yield to know more for the wards, but on exams, usually they'll give you a patient that's eligible for TPA, unless they're obviously not like actively bleeding. Then, after you've done the TPA or the CT is negative, you do the TPA, you'd evaluate with like a CTA or an MRA, which is basically a perfusion scan to look at the benefit of possible thrombectomy. So you can see the perfusion diffusion mismatch. Otherwise, they'll word this as you have a salvageable penumbra there, which is basically tissue that's at risk but can be saved if you were to take out that clot. So remember that thrombectomy is actually able to be done up to 24 hours outside of last known well. So this one thing that I got confused with learning this is that these are not mutually exclusive. So you can give TPA and go in for thrombectomy in the same patient later on, but definitely in a patient that's been longer than 4.5 hours since the last known well, consider thrombectomy as management of that patient, especially if you see that mismatch on the CTA. Um, yeah, so as you can see there, if it's greater than 4.5 hours from the last known well, or there's a contraindication to TPA, like in this patient, if they had an active GI bleed or something like that, you would move to a perfusion study right away to evaluate for a thrombectomy to see if you can still do something for them that's not TPA. So keep those things in mind. Very high yield ischemic stroke. So case 5, 64-year-old female with a past medical history of poorly controlled hypertension and diabetes presents to the ED with sudden onset headache with associated aphasia and right-sided paralysis. Her husband reports the symptoms began around 2 hours ago and progressed to her current state. On exam, vitals reveal hypertension of 170 over 110, and your physical exam reveals no further abnormalities. A non-con CT is shown below. What is the most appropriate next step in management to avoid further increases in ICP? So I forgot the image. I actually put it on the next slide. So this is an intracranial hemorrhage. As you can see, that big hyperdensity there within the cerebral hemisphere. Risk factors are going to be hypertension, amyloid angiopathy in the elderly is actually very high yield as well, and anticoagulant use, as that makes sense, right? The best first step, once again, in these patients that show sudden onset stroke symptoms, you got to get that non-con CT, and this is why, because you can catch the hemorrhage on the non-con CT. Then your next step is going to be to reverse any anticoagulants. I encourage you to go back and see the hematology video. We go over acute reversal of anticoagulation. PCC or prothrombin complex concentrate is going to be usually your reversal of choice for warfarin and the DOACs, which are usually the things that patients are outpatient. They're usually not on a heparin and then hemorrhage or whatever, because those have specific reversal agents as well. So then the neuroprotective strategies. So ways to lower intracranial pressure. This is high yield to keep in mind. So things we do, we raise the head of the bed. I think it's greater than 30 degrees, something like that. You hyperventilate the patient. You can do this with patient on ventilators. further sedation. You're going to treat fever if they have it, and then make sure that they are euvolemic in nature. So they may need to be monitored by neurosurgery. A craniotomy is a last resort in these patients. If the pressure, intracranial pressure, is too darn high, you might just have to do craniotomy to allow some of that pressure to be relieved, so we don't herniate. So, and then also controlling blood pressure to a reasonable degree. So usually these patients are placed on like a nicardipine drip, but also it's kind of important to know that usually in stroke we allow for a certain degree of permissive hypertension to maintain perfusion to the rest of the brain while the pathology is kind of going on. But you would want to control it to a reasonable degree. Remember, lowering ICP. This is what this is all about: is lowering the intracranial pressure with those means there. So case 6, a 46-year-old female presents to the ED after noticing increasing blurry vision and now trouble speaking over the last 12 hours. She's also experienced 3 episodes of diarrhea. It's winter and she reports being a beet farmer in a rural area. On exam, you note bilateral ptosis and some dysphagia when you ask her to swallow water. Vitals are stable. What is the next best step in management? So people are getting a lot better at asking this question. As you can see, we have GI symptoms and ptosis in somebody that has a risk factor for this sort of thing, being a rural area farmer. So this is botulism, specifically foodborne botulism in an adult. So this is going to present as descending paralysis. Typically, you're going to see ptosis and blurry vision first, then moving on to dysphagia, dysarthria predominating, along with diarrhea because it is a GI pathogen. Remember, you can cause respiratory paralysis, so you have to make sure the airway is protected. If they were to be hypoxic, if their respiratory rate was super low, that would be when you'd start moving towards intubation to protect these patients. The next best step, the important thing to know is that there is a botulism antitoxin. You can also help with a bowel clean out. That's also kind of part of the regimen for this, but really the botulism antitoxin is what you're going to be asked about. In adults, remember this is typically acquired via home canned foods. Now, they're not going to tell you they ate their home canned whatever food. They're going to tell you that they're a farmer in a rural area or, had a family reunion yesterday or something where that kind of stuff would be around. So this is due to the ingestion of the preformed toxin as opposed to kids and like infant botulism. That's due to like the spores of Clostridium botulinum in the honey. So remember, this is preformed toxin. In kids, it's from the spores. So keep those in mind. Case 7, a 27-year-old male with a past medical history of tobacco use disorder presents to the ED with stabbing pain that localized right behind his right eye. This has never happened to him before, but he reports that this comes on in short cycles, about minutes long each time, and the pain is unbearable. He also notes that he has increased tearing, and nasal secretions during this time. On exam, he's restless, and you note ptosis and meiosis, along with increased tearing and mucus discharge from the nose. What is the most appropriate next step in management? So hopefully this syndrome, especially with that periorbital terrible headache that comes in cycles, has some increased autonomic symptoms with it as well. This is a cluster headache. So the partial ptosis and periorbital pattern of pain is very classic. Classically, it's in young male smokers. That's just the demographic that they go after for whatever reason. It is more common in those demographics. That's why, but just it's commonly seen on exams, a young male smoker. The treatment for this is very high yield. It gets asked all the time. 100% FiO2. So hook them up and give them full strength oxygen. You can consider triptans as abortive therapy as well. It's kind of a similar to migraine type of pathology. And prevention with this is going to be verapamil usually. That's a non-dihydropyridine calcium channel blocker that you can use as migraine prevention. So remember the 100% FiO2 specifically in that demographic with those symptoms. Case 8, we have a 55-year-old male with a history of hypertension and polysubstance use, presenting to the ED with sudden onset headache, which the patient describes as generalized and with 10 out of 10 severity. On exam, he's confused and agitated with severe photophobia. His labs are largely unremarkable, and a non-con CT of the head doesn't show any acute abnormality. What is the next best step in management? Now, this is very high yield. So we have really sudden onset headache, 10 out of 10 severity, and you have the photophobia. So you really have, a worrisome combination of things. And a non-con CT doesn't show any acute abnormality, which you might be expecting it to. So what's your next best step? So this is a subarachnoid hemorrhage. So classic thunderclap headache, worst headache of my life, 10 out of 10, can rapidly progress. Most commonly, this is in the setting of trauma. But other than that, if it's atraumatic, then you're looking at like a ruptured Barry aneurysm. Remember, the best first step is still going to be that non-CT scan, non-con CT scan. You're looking for hyperdensity within the basal cisterns. You can kind of get a little picture of that over to the right. But the next best step, this is very high yield, in a negative CT scan, but you have a high suspicion, you have to do a lumbar puncture in these patients. And the reason for that is because you can actually catch the red-pink discoloration and then very later on being xanthochromia, which is very high yield for exams. That's the yellow tint of a tap due to heme breakdown later on in the process. So it's important because if you really think it's a subarachnoid hemorrhage, the non-con CT might miss it, and you have to know if it is. It's very important. The management's going to be blood pressure control. You're going to manage your intracranial pressure, things we talked about earlier, raise the head of the bed, hyperventilate, etc. Reverse their anticoagulants. You're going to really target euvolemia, euglycemia, eunatremia, with targeted temperature management as well. So keep all these things in mind. Subarachnoid hemorrhage is a scary pathology. You do not want to miss it. So if that non-con CT doesn't give you anything, you want to do the LP to rule it out. Case number 9, a 60-year-old male with past medical history significant for alcohol use disorder and chronic pancreatitis presents to the clinic with increasing fatigue along with numbness and tingling felt mostly in the lower extremities. He reports drinking 6 to 8 beers per day with frequent blackouts. When asked about his diet, he reports he usually eats food from the gas station where he works in the attempt to save money. On exam, vitals are normal, but you note some swelling of the tongue along with decreased sensation and vibration in the lower extremities and an ataxic gait. He also has an overall pale complexion. What would you expect to find on laboratory evaluation? So CBC, a peripheral blood smear, and then an MMA level. So this is subacute combined degeneration, really resulting from B12 deficiency in this patient. So progressive demyelination of the spinocerebellar, the lateral corticospinal, and the dorsal column of the spinal cord. So all of those are degenerated. So it's a combined degeneration. So really, you're going to present with the dorsal column defects, the proprioceptive vibratory sense deficits, along with the deficits from the other track. So you're going to have a little bit of spasticity. You're going to have ataxia as well. And this B12 deficiency, remember, that's a megaloblastic anemia, so high MCV. The PBS is going to have hypersegmented neutrophils, and then elevated MMA level, which is the differentiating factor on labs from B9 deficiency, folate deficiency. Remember that glossitis is actually a classic presenting feature of B12 deficiency. I see it on exams a ton. Glossitis in general can kind of point you towards vitamin deficiencies, so just keep that in mind. Management is going to be B12 replacement, and then obviously in this patient you need to do alcohol cessation or nutrition counseling. There is also some role later on. Remember, this is also another pathology to keep in mind. You may want to test for like anti-intrinsic factor or anti-parietal cell antibodies. Remember, that's your pernicious anemia. So especially if they don't have a history of alcohol use and malnutrition like this patient did, maybe checking for these, especially in a patient if they were to give you somebody that already has an autoimmune disease or something like that. Keep that pernicious anemia causing B12 deficiency and then subacute combined degeneration. Keep that stuff in mind. So case 10 now. A 21-year-old male presents to the ED after an episode at the grocery store. Per observer reports, he collapsed and started flailing uncontrollably on the ground. He was also noted to have some blood in his mouth along with being incontinent of urine. On exam, he's very drowsy, cannot recall any details of the event. Suddenly, the patient begins to flail uncontrollably once again. He's turned on his side and monitored, but this does not resolve after 5 minutes. What is the next best step in management? So this is epilepsy or an active seizure, or an acute seizure. So you want to know how to manage this. So remember, status epilepticus is a seizure greater than 5 minutes or greater than 2 seizures without return to baseline. This patient kind of fits both. So the seizure's gone on 5 minutes, and he's had 2 seizures without return to his baseline. He was still kind of post-ictal before he had the next seizure. So classically, incontinence, the tongue biting, so a little blood in the mouth, loss of consciousness with the ictal phase. That's a very important differentiator from other causes of loss of consciousness. So if you have the ictal phase, like this patient, he was still kind of confused, doesn't remember anything, kind of out of it after one of these spells, that kind of leans into more of a seizure in a post-ictal phase. So remember, this could be preceded by sensory hallucination. So they may say they hear something or they tasted something or smelled something and then had these episodes. The first step is always going to be to evaluate the airway. Remember your ABCs, and then IV benzodiazepines like lorazepam or diazepam to abort the seizure. And remember, if it's persistent, there are other options like fosphenytoin, valproic acid, Keppra, phenobarb, all of these things down this pathway. Usually, though, IV benzodiazepines is the answer for these. You then start continuous EEG monitoring to help diagnose. Usually, you do want a brain MRI as well. Remember the complications of seizure that can point you towards, oh, this is a seizure, not some other cause of loss of consciousness. So, a posterior shoulder dislocation, if you were to see that, that's specifically a seizure. Rhabdomyolysis, just due to the contraction of the muscle. So, if you're seeing AKI after seizure, that'd be where you're getting. And then lactic acidosis for the same kind of reason. For those continuous contraction, you're kind of using up all that energy really, really quickly and running out. So remember, evaluate the airway, IV benzodiazepines to abort the seizure in the acute setting. Case 11. A 32-year-old female with a past medical history of epilepsy on valproate presents to the clinic with questions about pregnancy. Her last seizure was greater than 5 years ago, and she reports no side effects to her medication to this point. Her vitals and exam are totally benign. What anticipatory guidance is most appropriate for this patient? So we are concerned about the interaction of valproate or valproic acid with pregnancy. So let's just go over some of the anti-epileptic drug side effects. So valproate, remember it's contraindicated in pregnancy or childbearing women because of the increased risk of neural tube deficits or neural tube defects. So remember that neural tube defects in valproic acid. It's also hepatotoxic and can cause tremor. Valproic acid-induced pancreatitis is also a tested complication. Move on to carbamazepine. Remember that one's associated with not only the neural tube defects, but also SIADH, agranulocytosis. And remember, on any sign of rash, and I would say kind of as a generalization, if they're on any seizure drug and they develop a rash, discontinue the drug immediately because there is the risk of Stevens-Johnson syndrome, which is basically like the souped up, worse form of toxic epidermal necrolysis. So remember, these are also teratogenic with associations with the neural tube defects, the cleft lip and palate, and it's also a CYP450 inducer. So you can get a lot of drug interactions with carbamazepine, which is why it's not used all that much anymore. Phenytoin, remember that can cause hirsutism, gingival hyperplasia, which is pretty actually high yield, fetal hydantoin syndrome, which gets tested a lot. So that's nail hypoplasia, craniofacial deformities, and then microcephaly are all kind of in that syndrome. And then remember lamotrigine. So this is the one that's most associated with the rash or SJS. So you have to discontinue lamotrigine with any sign of rash. So even if it doesn't seem significant, you don't even take the risk with lamotrigine. So keep those things in mind. In this patient, what you would want to do is you'd want to switch to something that is more benign in pregnancy. Because of the risk of neural tube defects. I think there is also kind of a real life caveat that you can actually like megadose folate, I believe, to kind of help with the risk if you really can't get off one of these drugs. But otherwise, that's going to be your management. So case 12, a 60-year-old male with a past medical history of controlled hypertension presents to the ED with a sudden onset of stabbing electric pain over his left face. He reports that this has never happened before and that it's a 10 out of 10 in severity. The episode started when brushing his teeth and it lasted for seconds and has since resolved. He had another episode on the drive to the emergency department when he was on the phone with his wife describing his symptoms. What is the most appropriate treatment for the most likely diagnosis? So really keeping in mind this electric pain over the side of the face and then the stimulus for this. So brushing the teeth, holding the phone up to your face. This is trigeminal neuralgia. So really this is defined by short episodes of severe stabbing or electric pain, strictly in that trigeminal distribution. So usually in the cheek, can go up towards the eye, even down into the jaw. Usually this is due to neurovascular compression, but it can also be due to a result of demyelination or CPA or cerebropontine angle tumors. So remember, if this is bilateral, specifically high yield for exams, if it is bilateral trigeminal neuralgia, that could be a sign of multiple sclerosis. That specifically happens there with the demyelination in that disease. The treatment for trigeminal neuralgia is oxcarbazepine versus carbamazepine. Usually oxcarbazepine has less side effects, but this is also a good chance for them to test the side effects of carbamazepine. So that's going to be the things like the SIADH, the agranulocytosis, the neural tube defects in pregnancy, things like that. So, case 13, a 35-year-old female presents to the clinic with increasing fatigue and impaired vision. She reports that this started 3 days ago and that is mostly affecting the right eye. On exam, vitals are within normal limits, but she displays pronator drift, nystagmus, and an electric pain is described on neck range of motion testing. A MRI of the brain is ordered showing diffuse lesions in the periventricular white matter along with enhancement of the right optic nerve. What is the preferred treatment for this patient and the most likely natural course of the condition? So keep in mind that final question, likely natural course, that's becoming more and more tested on these step 2 exams. So keep that in mind as we kind of go through this. So multiple sclerosis. This is classically a young female. It's associated with like the fair skin phenotype. It is an autoimmune process, although it is kind of poorly defined, excuse me. So really the presentation, upper motor neuron signs. So you got your pronator drift, hyperreflexia, optic neuritis is classic, along with the INO, deficit internuclear ophthalmoplegia. Generalized fatigue and malaise can be seen. This Lermeti sign, which is that shock-like sensation on flexion of the neck. And then this one actually gets tested quite a bit, the Utah phenomenon. So this makes the symptoms worse with increased body temperature. So classically, their symptoms of optic neuritis will get worse after a hot shower or something like that. Diagnosis is going to be done with usually with MRI showing white matter lesions, as you can kind of see on the MRI over to the right side of the screen there. They're kind of diffuse. It's kind of random in their distribution, and that'll kind of give you your upper motor neuron deficits, the location of them anyway. Remember, you can also do an LP. Their CSF will show oligoclonal bands and a lymphocytic pleocytosis. The treatment for this is really going to revolve around immunosuppression. So in a flare situation like this patient's in, high dose steroids is going to be your friend, but disease modifying agents are more popular now. So things like natalizumab Botulism, ocrelizumab are all immunosuppressants targeted at certain mediators that we found actually some decent help with. So the natural course of multiple sclerosis, the most likely pattern is classically this relapsing, remitting pattern of disease. So they'll go through a flare, they'll get better, they'll get worse again, and it'll kind of come and go with like a gradual kind of stair stepping down in the patient's overall status. But it is variable. There is a primary progressive form where it just continually gets worse and things like that as well. So, case 14, a 75-year-old male with past medical history significant for hypertension, diabetes, and chronic constipation presents to the clinic due to a recent pattern of falls. He reports falling twice in his house in the last 2 weeks. He also reports a tremor in his left hand. On exam, you note some mild rigidity and left-sided resting tremor that improves during finger-nose-finger testing. His vitals are within normal limits. What is the next best step in management? So this slide specifically, we want to go through the comparison between Parkinson's disease and Parkinson's plus syndrome. So remember that the classic presentation of Parkinson's disease that they test on exams is like the TRAP symptoms. So resting tremor, rigidity, akinesia, and postural instability. The diagnosis, though, it's very high yield, is that this is a clinical diagnosis. So there are MRI tests that can be done, like I believe the DAT testing is what's done. And you can do that to kind of support, especially in patients where you might not have the highest of clinical suspicion. But the highly tested point, you can use the PUL test for postural instability. That's something that's done in neurology offices sometimes just to kind of see how their instability is. Remember, the treatment for Parkinson's disease is going to usually be on exams, carbidopa, levodopa, along with additional agents. So usually those additional agents are going to be potentiators to kind of avoid the on-off phenomenon and things like that. Those are going to be things like pramipexole. They're going to be things like the other dopamine agonists as well. So remember, to compare with the Parkinson's plus syndromes, this is the high yield part because exams love to go after these. So if you have less TRAP symptoms, but you have a lot of autonomic issues, so like these patients have a ton of hypotension on standing, erectile dysfunction, and hydrosis, so they don't sweat at all. This is multi-system atrophy. So that's a whole different syndrome, but still in this related Parkinson's plus field. If you have retropulsion or like rapidly falling backwards randomly, less tremor, and you also have vertical gaze palsy, that's kind of getting you into PSP. Um, and then TRAP plus more dominant behavioral symptoms if you have a ton of hallucinations and really this prevalent sensitive to neuroleptics. So they were given some neuroleptic drug and then they get really sensitive to that side effect wise. That's Lewy body dementia. So all kind of related, but with different kind of sub characteristics in them. So keep those in mind. Case 15 is a 46-year-old male presenting to the clinic with a chief complaint of trouble swallowing. His wife also reports that he's been having more voice cracks over recent months. He reports some weakness of his hands, which he's noticed when doing work around the house. His speech is mildly slurred, vitals are normal, and exam is remarkable for mild spasticity of the lower extremities and atrophy of the right thenar eminence. He has intermittent fasciculations noted best in the hands. What is the natural course of the most likely diagnosis and the most common cause of death in patients with this condition? So, as you can see, we have some kind of some bulbar symptoms, voice cracking, some swallowing difficulty, but then also weakness of the hands with some spasticity and fasciculation. So a combination of upper motor neuron and lower motor neuron deficits. This is ALS or amyotrophic lateral sclerosis, so or Lou Gehrig's disease. The combination of upper motor neuron and lower motor neuron signs is classic. So these patients are going to display your hyperreflexia and spasticity, but at the same time have atrophy and fasciculation. So you're not just going to be able to call it a lower motor neuron or an upper motor neuron disease. So you can also the presentation of this, like the first signs, usually this is in the hands and feet, kind of in an asymmetrical basis, but you can also kind of start with this bulbar weakness. So that's how these patients get dysphagia, dysarthria, things like that. So the natural course of this disease, this is a progressive loss of muscle function, largely unsuccessful treatments. We don't really have much when it comes to treating this disease. We can add maybe months of life, if anything, and the most common cause of death, therefore, is going to be respiratory failure. Eventually, the diaphragm's not going to be able to move. They're going to progress to requiring like non-invasive positive pressure ventilation while awake, even, and eventually would require like constant respiratory support. Spirometry, if you were to do that on these patients, it is a restrictive disease because there's just not any movement of the accessory muscles of the diaphragm. Remember, the diagnosis of this is going to be done with electrodiagnostic studies. Usually you can see this with EMG and also ruling out other pathologies with imaging. But really, the clinical features of the upper motor neuron and lower motor neurons being combined, that's really your take home for this diagnosis. So case 16, we have a 78-year-old female with a past medical history of hypertension and hyperlipidemia presenting to the clinic at the behest of her children after being found in her car, not knowing where she was. Per their report, she's been having increasing trouble with short-term memory as of recent months, leading to some frustration with them having to repeat themselves often. She lives alone and is able to dress, clean, and cook microwave meals for herself. Her children provide other services and assistance. On exam, her vitals are normal and her physical exam shows some generalized frailty, but it's otherwise unremarkable. She has difficulty with serial sevens and with recall, but she is A and O times three. What is the next best step in diagnosis of this patient? So this is Alzheimer's disease, progressive dementia syndrome, with the most prevalent deficit being in short-term memory, along with visual spatial orientation and judgment. So this is really due to the disproportionate breakdown in the medial temporal lobe region, and specifically even getting into the hippocampus. The diagnosis is really done with a combination of neuropsychiatric testing and an MRI of the brain. So this is the same kind of workup that's going to go into all these new onset cognitive impairment. So neuropsych testing, MRI brain. If you have an MRI showing ventriculomegaly, prominent sulci, hydrocephalus, ex vacuo, those are kind of things, especially when you see it involving the temporal lobe, that kind of goes after Alzheimer's disease. But any dementia, you're going to do these things, neuropsych testing, MRI brain. You're also going to look at the TSH, vitamins, specifically like B12 and folate, medications to look at side effects for this workup of new onset cognitive disease. So keep those things in mind, the TSH, the vitamins, things like that. The treatment for Alzheimer's disease, what we kind of have in our bag is acetylcholinesterase inhibitors. These are things like rivastigmine. We have the NMDA antagonists like memantine, and then the amyloid beta biologics, which have shown kind of mixed data as far as results that we can offer these patients. There's no cure for Alzheimer's disease. Remember, we're going to focus on symptomatic and conservative management. Whatever we can do to kind of make their lives easier, that's what we want to do. Common complications of Alzheimer's disease are actually high yield as well. So aspiration events, they have trouble swallowing, feeding themselves, malnourishment as a result of that as well. Brain bleeds due to the atrophy, as well as kind of some interplay with the amyloid plaque distribution as well, causing like an amyloid angiopathy type picture as well. So keep all these things in mind. Remember that neuropsych testing and an MRI brain are kind of your big guns in diagnosis, but also to look at those sub tests, the TSH, the vitamins, the medications that are all reversible causes of cognitive impairment. So, special note here, I wanted to mention vascular dementia. So, it's starting to be commonly tested because of the nature of our population. We have a lot more people living longer, having a lot more vascular disease in general. Usually, this is going to be described in somebody with several vascular risk factors. So, they're going to be a smoker with hypertension, hyperlipidemia, diabetes. You'll have a progressive, kind of a stair-step pattern of worsening. So, they'll kind of describe that their symptoms started with only, a little bit of mild forgetfulness, but now you also have some other cognitive defects as well. The MRI would show multiple cortical and lacunar infarcts of different ages. So as you can see over here on that right side of the slide, there's multiple little spots, usually more in the basal ganglia type areas, or in the kind of the deep areas of the brain, the lacunar infarct areas, that you can kind of see those hyperintensities due to that tissue dying off due to being ischemic. The treatment for this, which is actually becoming very high yield, is risk factor management. So this is going to be your statins for hyperlipidemia. You're going to manage their blood pressure, you're going to manage their diabetes, do all that thing to prevent worsening because it's all centered around vascular pathology. So we want to optimize and decrease the damage to the vessel walls as much as we can. So case 17, we have a 72-year-old male with a past medical history of hypertension, hyperlipidemia, and mild cognitive impairment at baseline presenting to the ED, and he's admitted for acute cholecystitis. He's treated with antibiotics, and cholecystectomy is performed without any complications. In the evening of hospital day 3, nursing staff reports increasing confusion, disorientation, and agitation. They also report that this happened yesterday, and he was fully oriented during the day. On your exam, he's agitated and repetitively asking where he is, saying that he wants to go home to his mother. What is his next best step in management? So in this old patient already has mild cognitive impairment at baseline, and then now we have like post-surgery changes to his cognition that kind of waxes and wanes. So this is delirium. Risk factors are going to be like elderly age, cognitive impairment at baseline, metabolic abnormalities, post-operative, so surgery coming out of anesthesia, trauma, etc. You're going to look out for medications as well as kind of a risk factor. So if they take a lot of anticholinergics, if you use benzos in these patients, they're more prone to develop this kind of syndrome. The classic presentation is waxing and waning cognitive status. Often it's worse at night, and it's often improved by redirection or presence of family members, reorientation strategies. So your next best step is going to be supportive care. So things we do for delirium, we decrease the interruptions at night. We want to maintain their sleep if at all possible. Reorient the patient as much as you can. Maintain their hydration, nutrition, sleep cycle as best they can. And then antipsychotics like Haldol, Typically, they're deployed if the agitation or danger continues to persist. If they're like a danger to themselves, or if they're unresponsive to any of these other means, that's usually what you want to do. But really, the key in delirium is to do supportive care, conservative measures, get the family in there, help reorient the patient, tell them where they are, where they're at, why they're in the hospital, things like that, and you can really see some good results with these patients. So case 18, we have a 45-year-old female presenting to the clinic due to generalized weakness. She reports that she's noted an increased difficulty at work where she's a shelf stalker at Target. She also reports stairs are difficult for her. Along with this, she's noticed some intermittent blurry vision that's preceded the weakness. She's been seen by her optometrist and her prescription was updated, but this hasn't helped. On exam, you note normal reflexes and ptosis that is exaggerated by upward gaze testing. An anti-acetylcholine receptor antibody is ordered and is positive. What is the next best step in management? So we really give you the diagnosis with the anticholinergic antibody there, but this is myasthenia gravis. So remember, fatigable ptosis and proximal muscle weakness. So these patients are going to have blurry vision, trouble with stairs or combing their hair. That's proximal muscles needed to do those things. You're going to compare this with Lambert-Eaton myasthenic syndrome, which is usually a paraneoplastic syndrome, usually off of like a lung cancer or something like that. So Lambert-Eaton gets better with repetitive activity, whereas myasthenia gravis gets worse. So it is fatigable. Remember, you're going to have the autoantibodies to the acetylcholinesterase or the acetylcholine receptors at the neuromuscular junction. You can also diagnose this with EMG, and you'll see the fatigable waveform. So, like, you'll have different spikes in the muscle pattern after electric stimulation, and it will fade off as you continue to stimulate the muscle. The next best step is going to be a CT chest. There's actually an association with thymoma. So these thymomas, if you resect them, this can actually be curative for myasthenia gravis. So you're always going to want to screen these patients with a CT chest. The treatment for myasthenia gravis are acetylcholinesterase inhibitors to maintain as much acetylcholinesterase to kind of outcompete those antibodies. So these are things like pyridostigmine or things like that. And then steroids for flares. Now, note that if you're in myasthenic crisis, so these are patients that are having a ton of respiratory distress because their respiratory muscles are so weak. This is when like IVIG and plasma exchange start to have roles. But really, at baseline, you try to treat the flares with steroids and then maintain with acetylcholinesterase inhibitors like pyridostigmine. So there's this repetitive nerve stimulation test. So as you can see with myasthenia gravis, you're going to have it slowly fade off as you continue to stimulate it. While as with Lambert-Eaton, you're going to see if you continue to do it, it actually maintains full strength, but it starts a little bit less, but it slowly tapers up, and then you get up to your maximal state because it is improves with repetitive stimulation. So case 19, we have a 35-year-old male presenting to the ED with progressive lower extremity tingling and weakness. He reports that he first notices the tingling sensation about 36 hours ago, but has since lost the ability to walk. Records show that he was in the ED 1 month ago for supportive care for a presumed viral gastroenteritis. Vitals are within normal limits, and your exam reveals profound weakness and hyporeflexia of the lower extremities. These deficits appear symmetrical bilaterally. On an MRI of the brain and spine is without any abnormality. A lumbar puncture is ordered. What is the most likely finding on this diagnostic test? So this diagnosis, recent gastroenteritis, now has a seemingly ascending muscular weakness hyperreflexia. This is Guillain-Barré syndrome. So very high yield to know this pathology. It's more of an acute to subacute onset. So like within the 36 hours about there, you'll have the ascending paralysis, associated paresthesias. Classically, you'll follow either a diarrheal or a viral illness. Remember the association with Campylobacter jejuni as a pathogen for this. Your diagnosis is really going to be made with a combination of tests. So you're going to have a normal MRI. You're going to rule out spinal cord injury because this looks like spinal cord syndrome. And then LP with I can't even pronounce it myself. Albuminocytologic dissociation. So this is a very high yield point on exam. So you're going to have a high protein level, but you're going to have a normal white blood cell count. So make sure you keep that in mind. High protein with a normal white blood cell count. That's telling you that this is Guillain-Barré syndrome. The treatment is going to circle around like IVIG and Plex, but you're always going to want to assess the respiratory status. You're going to have a low threshold to intubate these patients as we just kind of got to kind of stop this process and make sure we stabilize the patient before we go about treating it. So keep that stuff in mind. But those LP results, very high yield. So you have case 20, a 55-year-old male presents to the ED after suddenly losing function in his legs while gardening. He has a past medical history of SLE on chronic prednisone and works as a contractor. He reports that when bending over in the garden, he had a sudden loss of strength in his legs associated with lower back pain. He subsequently fell but did not injure his head. On exam, he's in mild distress, and you note bilateral paresis of the lower extremities with associated hyperreflexia and numbness. These symptoms appear symmetrical on both sides. While in the ED, he has an episode of urinary incontinence. What is the next best step in diagnosis for the most likely incomplete condition. So this is kind of a scary syndrome. We have effect of the bladder and bowel function. We have bilateral upper motor neuron symptoms in the lower extremities. So this is some spinal cord syndrome. So the really high yield point here is to differentiate between conus medullaris and cauda equina syndromes. So conus medullaris, sudden onset, it's going to be symmetric, and you're also going to have more incontinence in that syndrome. So you're going to have bilateral lower extremity weakness, numbness, as opposed to cauda equina. That's a subacute onset, so maybe not as sudden. You're going to have kind of more radicular pain, an asymmetric picture of hyporeflexia and paralysis. So I kind of think of it because cauda equina kind of thinks about like a horse's tail. That's like the Latin behind the look of the spinal cord, and I think like the horse only has one tail, so it only affects one leg. That's kind of how I've always remembered it anyway. More associated with saddle anesthesia, also kind of goes along with the whole horse thing, but both of them can see saddle anesthesia. So that's like with the perineal numbness, and you're not going to see as much incontinence with cauda equina, but those are kind of splitting hairs. The etiology of conus medullaris and cauda equina is really herniated discs, mass effect. You can have subepidural abscesses that can do this, or spinal epidural abscesses, excuse me. Unstable vertebral fractures are another thing. So keep this in mind in your patients on chronic steroids, like this patient was, elderly women who are just at high risk for compression fractures anyway. But the next best step in diagnosis is going to be that urgent MRI of the spine because this does raise concern for cord compression. Treatment is going to be urgent surgical decompression with neurosurgery. Likely you'll get steroids as well for this. And then also in these patients, if you think they have spinal cord impingement, whether it's conus or cauda equina, whatever it is, always keep in your back pocket to bladder scan these patients to evaluate for urinary retention. That can be an easily fixable cause of some symptoms in the hospital there. So.